Today I am going to talk about laparoscopic abdominal cerclage over conventional cerclage in cervical incompetence or insufficiency. Laparoscopic abdominal cerclage is a very effective and safe surgical procedure in selective patients with recurrent miscarriages due to cervical insufficiency. Though it was first done in 1998 by Lesser, but I can say it as an underutilized procedure. Nowadays, it's gaining importance in the recent years. And cervical insufficiency is the inability of the cervix to retain the pregnancy till term in the absence of contractions. Usually, patients present to us with painless dilatation of cervix with bulging bag of membranes, followed by rupture of membranes and expulsion of the fetus in a very short duration of time. Its incidency is around 1% of all pregnancies and 8% of pregnancies with previous miscarriage. And the reasons for cervical insufficiency, though majority of the times are unknown, it is believed to be due to a structural defect or a functional defect in the cervix. Most of the times the reasons will be Mullerian anomalies or connective tissue disorders and cervical trauma due to previous surgeries like LEAP, conization, trachelectomy, and excessive dilatation of the cervix during procedures like VNC and hysteroscopies or traumatic vaginal deliveries leading to deep cervical lacerations. And what has to be done? Cervical encerclage is the definitive treatment of choice. Cervical encerclage not only provides structural and mechanical support to the cervix, but also helps in maintaining the endocervical mucus plug. It is a very important thing in preventing ascending infection leading to preterm labor. So, the recurrence of cervical insufficiency, if we don't perform a cerclage, is around 72%. With transvaginal cerclage, the recurrence we can reduce to 30%, and with transabdominal cerclage, the recurrence of miscarriage we can minimize to 5%. With this data, you can understand the superiority of transabdominal cerclage over transvaginal cerclage. The different types of cerclages we know are commonly performed procedures. Vaginal cerclages are McDonald's. It's a low vaginal cerclage and it's a common procedure in obstetric practice. Whereas Schrodger's is a high vaginal cerclage. In Schrodger's procedure, we place the cerclage after mobilizing the bladder upwards and opening the pouch of Douglas. And the principle in any cerclage is to place the knot as high as possible, close to the internal os. Even in the hands of an expert surgeon, it's not possible to place the knot at the level of internal os in Schrodger's cerclage. Maybe at a level 1 centimeter below the os we can place. So there lies the importance of transabdominal cerclage. In transabdominal cerclage, we can place the knot exactly at the cervico-ischemic junction. So we can do this procedure by open or laparoscopic method. There is one more cerclage called rescue or emergency cerclage when a patient presents with us in active dilatation of the cervix with bulging bag of membranes. Usually the underlying chance of infection will be more in rescue or emergency cerclage. According to literature, maybe we can prolong the pregnancy by 3 to 5 weeks with rescue. So in that case, better to go for a vaginal cerclage instead of going for a laparoscopic cerclage. When the abdominal cerclage should be done? In cases of extreme cervical shortening, when unable to place a vaginal cerclage, and previous one failed vaginal cerclage. There are studies supporting the abdominal cerclage. It's a retrospective study of 300 women who have previous history of preterm labor. They were done open and laparoscopic abdominal cerclage, taking their prior pregnancy as control. The neonatal survival rate and average gestational age at delivery was prolonged with abdominal cerclage when compared to their prior pregnancy. And this is one more landmark trial. It was published in 2020 Obstetrics and Gynecological Journal. It's a maverick trial. It is a multi-center abdominal versus vaginal randomized intervention of cerclage. In this cerclage, 111 women with previous one failed vaginal cerclage were taken into study, and they were randomly allocated to some into abdominal cerclage, low vaginal and high vaginal cerclage. The results were showing that preterm labor incidence is only 8% in the abdominal group and 38% in the vaginal cerclage group. And then what are the advantages of abdominal cerclage? Due to its anatomical placement, it provides greater structural support to the cervix. And there is no foreign body in the vagina, So with that, we can reduce the risk of ascending infection leading to preterm labors. And patient can be allowed to move around after the surgery. There is no need to stick onto the bed. So, and the chances of suture migration will be less in abdominal cerclage. And we can leave the suture for future pregnancies also. There is no need to remove and place the cerclage again in the next pregnancy. Then, which cerclage is better? Either cerclage through laparoscopy or laparotomy. Movard et al. Performed another large systematic review of 40 studies. Among them, 25 were done with laparotomy and 15 studies done with laparoscopy. The results were showing the laparoscopy group had a higher rate of deliveries after 34 weeks, around 82.9% compared to 76% in the laparotomy group. And laparoscopy group also had fewer second trimester losses. With this, we can understand the superiority of laparoscopy over laparotomy. What are the advantages of laparoscopy? We can say all the benefits of minimal invasive surgery like reduced blood loss, less hospital stay, rapid recovery of the patient, and one more main advantage is we can have better visualization of pelvic anatomy in laparoscopy. That allows careful dissection on better delineation of uterine vessels, causing less damage to the uterine vessels. And the post-operative adhesions will be less. Suppose if the lady is a case of previous cesarean section, then we can better do the adhesolysis. Then after having all these advantages, then why not it is commonly performed? Due to the associated injury of uterine vessels, and it needs high level of surgical skill and expertise in the surgeon. Suppose if we perform the procedure in pregnancy, there is difficulty in manipulating the curved uterus, and the chances of perioperative pregnancy will be more, and potential requirement of cesarean section or hysterectomy for delivery, or if any loss of pregnancy is there. So after that, we have to decide which is better, vaginal cerclage or abdominal cerclage. Usually people think vaginal cerclage, lower risk overall and vaginal delivery is possible, whereas in abdominal cerclage the morbidity will be more and cesarean section is needed. But we have to think the other way. Suppose if a woman has more losses of pregnancy, recurrent miscarriages, then going for an abdominal cerclage and another cesarean section is not much a problem for her instead of going for a loss. Moreover, preterm deliveries cause extensive financial and economic burden to the family. So, indicated cases better go for laparoscopic abdominal cerclage. Then, how to go for the procedure? How to go for the procedure, like when to do, and it is better to perform the procedure either in the preconceptional or interval period or during pregnancy at the end of the first trimester after ruling out the fetal anomalies. The suture material used will be non-absorbable double leading 5 mm Meslin tape, most commonly used. Preoperative preparation will be same like conventional cerclage. The stitch is to be taken medial to the uterine vessels into the cervical stroma. The anterior landmark of taking the bite will be at the ascending level of the uterine artery, and the posterior landmark will be 1.5 centimeters lateral and 1 centimeter above the uterosacral ligament attachment. We have to place the stitch at the avascular space around the cervix. Then here I am going to show a video of the procedure done at our hospital. She is a case of gravida 4. I'm not able to play the video. We have done the procedure at around 14 to 15 weeks of gestation. I'll go through the practical aspects in this video. I will do is introduction of the Meslin tape into the abdominal cavity before starting the procedure. And the Meslin tape better to coat with adequate lignocaine jelly or betadine so that we can negotiate through the cervix easily. And then, as usual, we have to open the UV fold of peritoneum as the first step, and the incision is to be given liberally from one round ligament to the other ligament, and bladder is to be pushed downwards adequately. And the important precautions we need to take in pregnancy are because of the softness of the tissues, we don't get haptic feedback as in non-pregnant. The cervix will be soft and the tissues will be more edematous with increased vascularity. So we need to take precautions while doing in a pregnant. We usually take the stitch anterior, not anteriorly. So the first bite would be from posterior to anterior on one side of the cervix, and the other side from posterior to anterior on the other side, and tying the knot anteriorly. After tying the knot is to be secured with 2-0 silk to avoid slippage of the knot or erosion into the bladder, and then closing of the broad ligament windows and UV fold of peritoneum. And the contraindications of cerclage are if a patient is in active labor with uterine contractions and presence of chorioamnionitis or conditions like bleeding PV due to abruptio placenta or preterm pre-labor rupture of membranes and intrauterine death or lethal fetal anomaly. And when to do the cerclage, whether to do preconceptional or during pregnancy. According to study by Dawood and Ferguson, it was better to do the procedure in the preconceptional group when compared to pregnancy because that gives good results with less surgical complications. And performing the procedure in the preconceptional does not interfere with conception. And we can allow for termination of, suppose if any missed abortion or miscarriage happens, we can allow DNC or suction evacuation safely up to 12 to 13 weeks. And in literature, it was shown that around 18 to 19 weeks also, abortion was allowed without disrupting the cerclage. In cases of IUD or PROM, preterm labor, after second trimester, maybe we can remove the suture either through laparoscopy or colpotomy. These are the recent modifications to laparoscopic abdominal cerclage. Shin et al. They have done in 2015. They have performed the cerclage not going medial to the uterine vessels, but lateral to uterine vessels. Suppose if we start in the middle of the surgery because of some adhesions or technical difficulty, we can even go later to the uterine vessels also. And later follow-up shown that it does not interfere with fetoplacental circulations and not cause any IUGR also. And Wang in 2019 modified laparoscopic cerclage by placing the knot in the vagina. So laparoscopic cerclage with transvaginal knot removal. And then it will be easy for many of the people who think that if any removal of cerclage is needed, we need to go for laparoscopy or laparotomy. In that case, we can remove the knot vaginally. And again, so what is the future and scope of laparoscopic cerclage? Still more studies with large sample size are required to evaluate which technique is better, whether medial or lateral to uterine artery, and what is the knot position, whether to go anterior, posterior or vaginal knot, and what is the most efficient tape, Merslin or Prolene tape. If we use Merslin tape, it causes more fibrosis of the tissues and but it sustains uterine contractions well. Whereas Prolene tape, as it is monofilament, it does not interfere with tissues and we can easily cut and remove the Prolene suture, but it has the tendency to cut through the tissues. Then what is the best timing to perform the procedure, whether preconceptional or pregnancy? And so my conclusion is a timely placed and well placed stitch saves precious life. So previous one failed vaginal cerclage itself we have to take as an indication for abdominal cerclage. Waiting for 2 vaginal previous failed cerclages may be a high threshold. Thank you.